السلام عليكم ورحمة الله وبركاته. مساء الخير. Welcome everyone. Inshallah, we're going to start the final session of the academic program, ختامها مسك, with advanced imaging. I'll be more delighted to co-chair this session with my colleague, Dr. Riyad Al-Kuradi. And we'll start our presentation with Professor Dr. Azza Farag. Dr. Azza is a full professor of cardiology in Cairo University, and she is the vice president of Egyptian Society of Cardiology. She's the head of the Egyptian Echocardiography Working Group and a board member of Egyptian Society of Hypertension, head of non-invasive cardiac lab at Qasr Al Ain School of Medicine. We are very delighted and happy to have Dr. Azza with us, and she's going to talk to us today about the application of 3D imaging in clinical practice. Dr. Azza, the floor is yours.
It's an honor to be here for the second time in the Libyan Society of Cardiology. The last year was in Misrata and this year in Tripoli. So I'm really honored to be here with you. My talk is about 3D echo. What does it add in the clinical practice? I think 15 minutes is too short to talk about 3D in details, but I try to make it more easy and more short for every point in echocardiography. So we all know that every imaging techniques in cardiology, including the very primitive chest X-ray passing through the cardiac catheterization, CT, and CMR, still echocardiography has its glory role in managing and diagnosing different cardiac pathologies, including the chambers, the great vessels, and the valves, of course. Being non-invasive in nature, being time and cost effective, the bedside availability in the clinic, in the emergency ward, or in the operating theater, the uncomplicated use in children, pregnant women, or any patients with pacemakers and cardioverter defibrillator can be managed safely and diagnosed safely with echo. Starting from the M mode in the 1970s, passed through the two-dimensional echo in 80s, and the first reconstruction images of 4D echocardiography in early 1990s. Still, the echocardiography is the top class for the first diagnostic imaging modality. 3D echocardiography first utilized by Decker in 1974, where it was just an idea, using a transducer attached to this huge mechanical arm that fed quadrant of data to be reconstructed and make what's called the three-dimensional technique. These reconstructed images brought to the market after about 20 years, and with the development of the what's called the freehand methodology. I mean, you have a probe in your hand and you can examine your patient. In 1995, 30 years ago, the first reconstructive three-dimensional imaging using the transesophageal probe was obtained and brought to the market. To know what's the importance of 3D echo, by the end of 1990s, researchers at Duke University produced the first transthoracic probe that could acquire volume data rather than single slice. Single slice, I mean the M mode or the two-dimensional echo. This transthoracic probe had the elements configured in a sparse array pattern, not fully sampled transducer. You must know that each probe at that time contains 128 elements were used for transmission and release of imaging. Nowadays, you have 3,000 active elements in the footprint of each transducer. So at year 202, an advanced form of real-time three-dimensional imaging. The previous images was not real-time, just reconstructed images, but the real-time appears by early in this century. The fully sampled dense array transducer, as I said, which was the matrix transducer belonging to one of the vendors in pioneer in echocardiography, and the significant technical advances was required for this electronic piezoelectrical crystals to be miniaturized into a small footprint of the transducer. So we changed from A mode to B mode to three-dimensional data set, or what's called the pyramidal shape images of real-time three-dimensional echo. So how is it fit into the clinical routine? This three-dimensional echo, does it available? Does it cost-effective? So we have a lot of challenges to introduce the three-dimensional echo in our echo labs. The training and the workflow, the limitation in terms of image storage and transmission. The image storage is very important. You cannot store the images of three-dimensional echo like the two-dimensional echo or the M mode. How do echocardiographers interpret these 3D dimensional data? How do echocardiographers make use of this wealthy data in a timely fashion? And does it cost effective if you have money to buy a machine? Does you pay this money for three-dimensional echo or not? So I think that the time to adopt real-time three-dimensional echo in our lab in the clinical routine is now, if not yesterday or the last year or the last 10 years. So what are the clinical applications for three-dimensional echo? We have primitive indications or primitive application concerned with the transthoracic probe, which is the chamber quantification, the size and function, the contrast enhanced 3D echocardiography to facilitate the proper images. And of course, the more advanced modalities or the more advanced applications for the three-dimensional echo concerning the valvular heart disease and the surgical or the percutaneous intervention, whatever, for the valves like the TAVR or the mitral clip or the TEER, for example, and the congenital heart diseases. And there is a new software for these from different vendors. One of them is called the CFQ. CFQ is the color flow quantification, how to quantify the color to get better estimation of regurgitant lesions, especially the mitral regurg and the tricuspid regurg. So if we talk briefly about the transthoracic echo 3D application, is the echocardiographic evaluation and quantification of the left ventricle. It's very important for diagnosis, risk stratification, and therapeutic guidance. So it should be part of routine examination, whatever your technique is, two-dimensional or three-dimensional echo. So if we talk about left ventricular estimation by the ejection fraction, by the Simpson rule, it has a lot of default and a lot of limitations, like the geometric assumption of the left ventricular shape. You assume that the ventricle has a specific geometrical shape, which is not true. The apical foreshortening, and you can know what's apical foreshortening when you found that the apex is contracting. You must see the apical cape is not contracting to be sure that your captured image is true. And the image plane error, I mean by the image plane error is that most of our machines have the apical fourth chamber considered perpendicular for the apical two chamber. This is not true because the apical fourth chamber is perpendicular to the apical long axis. This is the 90 degrees. So we must choose our ejection fraction based on these two views. So by estimating ejection fraction by three-dimensional echo, we have no geometric assumption, we have no apical foreshortening, and we have no image plane error. I just want you to know something, that ejection fraction is one of the parameters that can represent the left ventricular systolic function, but it is not the sole criterion for left ventricular systolic function, because it is not only the longitudinal motion of the left ventricle or the inward motion, but also you have the twisting motion, the twist and the untwist. If we consider that each part of these motions, considering 15% for the longitudinal motion, 50% for the inward motion, and 15% for the twisting and untwisting. So the collaboration between these three types of motion will be responsible for the other 15% that represent the 60% of the ejection fraction. I think not all patients requiring three-dimensional assessment, but it is very important for patients with distorted ventricles, like patients with different types of cardiomyopathy, like here hypertrophic obstructive cardiomyopathy, or patients with dilated cardiomyopathy, or patients with multiple akinetic segments, so you cannot accustomed for estimating the systolic function only in M-mode or in Simpson rule. Also, patients needing frequent assessment of this left ventricular contractility, like patients receiving chemotherapeutic agents. So, three-dimensional evaluation of the left ventricle is has sufficient evidence in the literature to support it should be part of the routine daily practice, because it's easy to capture the imaging and it doesn't need a transesophageal probe. These images is correlated with two-dimensional summation images of angiocardiography and three-dimensional MRI, and you can show here how much is the 3D versus CMR has no significant figures, but with 2D there is significant difference between the two-dimensional volume estimation and the CMR image estimation. It is not only the global left ventricular function, but also the regional. When you divide the ventricle into 16 segments, and the 17th one is the apical cap, each segment has a color and can give you a curve that you can estimate the function of each segment from the 17 segments of the left ventricle. Again, this can be used a clinical application to estimate the degree of left ventricular dyssynchrony. When you measure for a patient or evaluate a patient for CRT, I know it is not present in the guidelines, but I think it will be soon present in the guidelines, so you can estimate the degree of dyssynchrony through the systolic dyssynchrony index. Stress echo by 3D is usually used, يعني الحقيقة هو used على استحياء. It is not used for routine, but you can estimate objectively and not subjectively if the patient has something related to myocardial ischemia through increasing the left ventricular in systolic volume in relation to the end-diastolic volume. The contrast enhances 3D echo to improve the image quality, and one of the most important softwares present in different vendors is related to how to see the cardiac masses. Of course, you cannot confine yourself to a pathological diagnosis for evaluation of cardiac mass. You can just illustrate and evaluate the shape, the anatomy, and the physiology of this mass, how it be introduced or bulging into a valve or the inflow tract of the left ventricle or the right ventricle, but you cannot call it, this is a leiomyosarcoma, this is not a hemangioma, this is not a sarcoma or a myxoma, but you can estimate this by knowing your experience and the anatomical relationship and the position and the shape of this mass. So a lot of software can help us to delineate the nature of cardiac masses. So what about the valvular heart disease, which is the main era today is about the evaluation of valvular dysfunction, mainly the stenotic valve, and sometimes the regurgitant mitral valve for percutaneous intervention. So quantification of geometry of the mitral annulus, the leaflet surface, tethering distance, and tenting volumes, relationship between the mitral apparatus and the position of the papillary muscle, and also the LVOT, as I will show you shortly. Reconstruction of the aortic valve is feasible in more than 80% of patients, and numerous case reports now talking about the tricuspid valve disease. You can see by the 3D the valves, the mitral valve, the different scallops, and the position of each scallop, and if there is abnormality related to any of these scallops, as in patients with floppy valve syndrome or mitral valve prolapse. Also, patients with mitral stenosis, you can see different types. The relation of the commissure, the presence of calcification in the commissure is very important to perform percutaneous coronary intervention and not to get out of your cath lab with a significant mitral regurgitation.
Dr. 2 minutes, okay?
Okay, reconstruction of the mitral annulus is very important to assess for functional mitral regurgitation, and if you need a transcutaneous edge-to-edge repair or not. Prosthetic valve is very clear to be assessed, especially the occluders and any presence of masses into the prosthetic bileaflet valve. Intraoperatively, this is very important to assess for percutaneous aortic valve replacement or aortic valve implantation, and also for, as I said here, it is very important to assess for the valve location, the valve landmarks, and the valve surface to know the relationship between the mitral inflow and the left ventricular outflow, because sometimes when you insert a valve, percutaneous mitral valve implantation, you can encroach on the left ventricular outflow tract and get out of your cath lab with left ventricular outflow obstruction. There is a very good correlation. Dr. Haitham will talk about the cardiac CT, a very important correlation between the three-dimensional echo measurements for TAVI and the planning by CT. So our future perspective is it is a routine modality in transthoracic study. Yes, it is a transducer with a small footprint is already brought to the market. You have very small printed probes nowadays, and there is a TE probe for pediatric with some vendors. New probes with capability of different modes of imaging, 2D and 3D. And of course, this is very nice to introduce a very new softwares for assessment of regurgitation, more precise and comprehensive assessment of cardiac pathologies, and of course the software will help us in collaboration with the Department of Biomedical Engineering in Faculty of Engineering. They know what we need to improve this software and embed it into the different vendors and echocardiographic machines. Thank you very much.
We're going to go to the next speaker on a question at the end. Thank you very much. Next speaker is Dr. Haitham Boughnia. He is a board-certified cardiologist with Geisinger Health System in USA. He has advanced training in cardiology. He started with Imperial College. That's where he board start training in the UK. And then he moved to US to continue his training. He completed his cardiology fellowship at Wright Center for Graduate Medical Education in Scranton, Pennsylvania. Dr. Haitham Boughnia his clinical expertise includes echocardiography, nuclear cardiology, and cardio-oncology, and advanced cardiac imaging. As an adjunct assistant professor of cardiology at Geisinger, he combines his academic background with strong commitment to delivering comprehensive patient-centered cardiac care. Stage is yours, Haitham. Thank you.
Thank you, Riyad. I think it's completely unfair to give a cool topic to Dr. Azza and then ask me to talk about cardiac CT apps in 2025 in 15 minutes, but I will do my best. So I'm going to tell you how cardiac CT changed my practice. We can't cover everything, but I'll tell you the most important things. I'm not going to steal thunder from the other presenters regarding the overlap, with the other applications, but in this case, we will try to cover the most important things. Usually, I try to start with a case-based discussion. You start your day sometimes, it's in the ICU, CCU, consult floor. You have sometimes residents, you have fellows with you, and then you start, with complex cases, cardiogenic shock, complex cases, and then when you go to the office, you're going to tell the students or the residents or the fellows that, we're going to talk about calcium scoring. And for them, they think initially that maybe it's a little bit boring, but, then they realize that, sometimes it makes a big difference. So, and every day it's office routine. You'll see, I'm sure that you will see similar cases. Sometimes the patient comes to you, tell you that, I did see one of my brothers, or my brother had a sudden death, and I'm really worried about my health. I want to be proactive. And it's a very traumatic experience, emotionally traumatic experience, and they looking for answers. Sometimes, it's about medicines. You want to convince them that you need to be on medicines. And other patients, this is like maybe a couple of weeks ago, she comes to you and will tell you that, my doctor wants me to be on statins, but, I'm worried about the side effects. There are different types of side effects. It could be, it's muscle ache. It could be they will tell you about that my lipids is going to go down. I need some lipids for my immunity. I need some lipids for my brain as well. So this, I'm sure that you faced similar encounters. So this is when it comes the rule for calcium score. Calcium is, and when it comes in the coronaries, is really a good surrogate for coronary atherosclerosis. If it's there, then you can tell that something happened over the last maybe 10 years. It's independent predictor. So usually what I tell my patient that this is like a scar. This is something happened. If there's something happened over the last 5-10 years, it can happen again. There's something else it can happen. Versus especially when they come to you and they tell you that they have a family history of coronary artery disease, or my father just had a sudden death. We don't know. We don't have genotyping for coronary atherosclerosis. It could be pulmonary embolism, especially if there's no autopsy. It could be pulmonary embolism. It could be a stroke. It could be anything. So we go with phenotype here. In this case, calcium, it is going to help you for sure in this case. And this is very convincing. You see on the left, at least on my side, there's no calcium. And here on the other side, there's some calcium there. So there's something just happened in that coronary artery, and it can help you to do some risk stratification and to answer the questions for your patients. So this is just to tell you that when you have a calcium of 0, the chance that at least over the next 5-10 years, the chance that you will have a cardiac event is low. And if you have a calcium between, let's say, 1 and 100, your chance of having a cardiac event will go up by 4 times. And if it's more than 300, then it's even significantly worse. And I have another cool slide. It will show you how important is the calcium scoring in your daily practice as well. So this looks obvious. When it's 0 is 0, we use the power of 0, and the chance that you'll have a cardiac event over the next few years, is low. And if the patient had a family history, at least you can tell them, probably you're not involved, so this. Genetic is not getting you, so your chance of having a heart attack over the next 5 years is low. Now, there's always a stress the fact that this is, if your patient is younger than 40 or 45, calcium score is not going to help you a lot. So we're talking about patients older than 45. If they are younger than 40 or 45, probably you have to be careful. You have to use other tools. And if it's between 100 and 300, it's in the moderate range. Greater than 300, it's severe. Some societies, they use the word extensive, or sometimes you can use extensive when it's greater than 1,000. So this is for the calcium score. The other thing, it's a very easy test to conduct. It's a very easy test. You don't need a cannula. There's no dye. You don't need contrast. You don't need IV. It will take maybe 30 seconds to do the test. They can do it sometimes even with their own clothes. It's very easy. I tell them you need only 1 heartbeat to do it. So sometimes some patients, when they are nervous, when you tell them that this test is not that, it's not like the MRI. They have the experience sometimes MRI or cardiac CT. I tell them that, your head is going to be exposed, so it's going to be quick. So usually with nervous patients, it's making their life easier when you explain it to them. And then, always I try to help my other, referring physicians, other doctors, tell them that's how this scoring system is going to help you. When you show that it's helpful and useful, then you will be convincing. So we usually, when we see our patients, mostly when they are in the intermediate range, you can use different tools, for risk stratifications, ACC, Europeans, anything, but when they are in the intermediates, calcium score, it is going usually, sometimes you think that they're intermediates, you have your goal for the LDL, and then you realize that they have a calcium of 1,000. And then, in this case, instead of intermediate, you know that they are a high risk, and then your goal for the LDL is going to change. And this is a game changer for you. And around 15%, some studies show that around 15% it will go higher. And almost, now it's more than, almost 2/3 actually, they will go lower. They will be, instead of intermediate, you realize that they are a low risk. And they want to be on statins or aspirin when they are a low risk, then sometimes you can change it, and then you can justify it. I think I have another one. Yeah, so, and then, when you have a calcium, the power of 0, when you have the power of 0, using statins probably is not going to help you. The number to treat is going to be low. And if your patient is not convinced, they will tell you that the first lady, I'm really worried that, statin is going to cause some side effects. And you do a calcium score, and the calcium score is 0. then it's okay. I think it's justified to go without statins in this case. Versus, so if it's extensive, then, you try to convince her, and I will show you some images where patients are going to be more convinced. And if it's extensive, then, so it's going to be a different story. So when this is going to help you, if you do a calcium of 0, how this is going to help you? It's going to be very helpful for your patients, and then it can help you with the risk stratifications. As you see here, that sometimes middle-aged or older patients, and they have intermediate or low risk, then this is going to help you. And the other thing, how many times, is when we do scans, patients go for a screening for lung cancer or for any other reason, and then it'll come back to you to tell you that the patient has some calcium, you need to do some risk stratification. This is on one side, versus if the patient never had a scan, and then you do the calcium, and then it's 0, then it's going to be a really a game changer for your patients. I'm going to come back to this in a second. Now, the other, so statins, we have, risk stratification. You can use the calcium score. You can use your other tools. But who is not confused about aspirin here in this room, about the rules? When do you have to take aspirin? When you have to stop it? Over the last 10, 15 years, if your patient is older than 70, don't give it to them. If your patient is 60, maybe 8 years ago, still you have used calcium. So it was very confusing. Now, we have some data which can help us, for this. So as you see here, the red line, above the red line, when you have a calcium of 0, this is the number of people to treat and the number of people to harm. So anything below the red line, this will show you that, there will be less harm, when you give them treatment. So when the calcium is 0, when you use aspirin, if you have your patient has some bleeding, then, it's not easy to justify. So if you have patients with 0 calcium score of 0, then maybe there's no need to use aspirin. Now, here we are talking about primary prevention. It's not secondary prevention. Because I have some of my patients, when they heard about this, and they have a stent a week ago, and then they stop the aspirin. So this is sometimes really scary. But if your calcium is 0, and in general, if the calcium score is greater than 100, at least in my practice, I justify the use of aspirin, 81 milligrams, for prevention. Talk about here prevention. And then, when it's in the mild range, then, it's, now, we talk about there's no other risk factors, of course. The patient is not diabetic. They have no family history of premature coronary artery disease. And sometimes, I use lipoprotein A as well. So I don't know how many people they have this. So we're going to keep moving. So, yeah, so this is, I think, is a cool slide. So in the here, when you see that the extensive 300s, and there's another line which is overlapped with this, which is those people that had a heart attack already. So people that had a heart attack a week ago versus a patient who never had a heart attack, and then they have a calcium score of 300. It's the same. So what I do, I tell my patient that I am going to treat you like you had a heart attack yesterday. So this is very important as well. So when they have a calcium score of 300, and they never had a heart attack, I think you should go with the LDL should be less than 70. If it's extensive, it's 1,000, it should be less than 55. This is another thing. This is from the Jack. I think is going to help you a lot if you want to use it, and it will give you some risk stratification when the calcium is 0. Always the question, when should I do another calcium score? And you can do it in 5 years if they have no other risk factors. If they are diabetic, if they have other risk, then you can do it in 3 years. And then you can go if it's 100 and 200 or greater than 500. And I told you that it's unfair to cover cardiac CT is 15 minutes, so I'm going to keep moving here. And then in this case, I can use Riyadh as an example here. That's always, we tell them that, you have calcium score, and then we're going to give you some pills, and then you're going to be fine. You prescribe the medicines, patients go home, and then, they have to pick up the medicine from the pharmacy. They have to go and take it every day. It is not an easy task. But when you show them the calcium, and especially when it's really extensive, then it's going to make a difference. So they did a lot of studies showed that, make a big difference. Calcium, you can use the calcium score, and you can use it for the aorta as well. You can use it for risk stratification. You can use it for paradoxical, low flow, low gradient aortic valve stenosis. This is a really good paper if you want to use from Jack Imaging. It's going to tell you about when do you have to use calcium and calcium scoring and how. But here, from the Mayo Clinic data, if it's greater than 1,200, then you can use it justified. Usually hemodynamically, there will be a significant aortic valve stenosis, and for men is around 2,000. So now that we're going to come, I will try to cover over the next 2 minutes CTA, which I don't think I will be able to do this. But anyway, CTA is very, very important. You can use it. This is what it's going to be even more convincing. It will take only 5 to 10 minutes for people with experience to do the interpretation. It's just thin slices, and the test is going to only take 20 minutes to do this. And how can you resist this? It's very obvious. You can see the left main, and how many people in the room where they did see usually some complication with a cardiac cath over the last month. We see them every day, and I'm one of them. Just last week I have a patient with a very experienced intervention who had a dissection of the coronary arteries. So sometimes it's just the right thing to do. You can't resist this. When you see this, this is left main. It has no disease versus there's some disease on the other side. And it's very convincing, and it's very cool when you show it to the other, physician, referring physician, and it's very convincing. Even interventionalists, so with them, sometimes it's very convincing for them. You can use it when there's some myocardial bridging. It is very helpful. You can use it as well. It's very obvious when you see it, and it's going to help you with your practice. Sometimes, it's very tough, especially with patients who had open heart surgery a long time ago, and then with cardiac CT, I think it's going to be even easier, at least in my opinion, to figure out, what kind of grafts they have in the past. Radiation is not that much. For the scoring system, it's like a mammogram for the cardiac CT with the advanced imaging, the 256. We're talking about 1 to 3 millisievert, so it is fair compared to the other cardiac imaging modalities, including cath and nuclears. It's really sensitive and it's specific compared to other imaging modalities. So it's well known that, so if you do a CT, your chance of survival down the road, it is higher. So for this, and we're talking about, other stresses. This is what I want to show you. The ischemia trial was a very cool trial because it showed that this cardiac CT, it is, it's going to help you. It's going to be your friend. I do all modalities of testing, but with functional testing, how many times did we miss that triple vessel disease? It's a good number of times. We miss it a lot. And in the ischemia trial, if your test is normal, actually, usually the outcome sometimes is a little bit worse, because there's a high chance that you're going to miss something. And this is what's really changed our practice, in this case. And it comes with the chest pain guidelines. I don't think we'll have time to cover this. But my point, at least I covered the initial part with the calcium scoring. There's a lot of things we can cover with cardiac CT. I want to make sure that I cover this point at least. With cardiac CT, many times we have it in the moderate range. And in the moderate range, what we used to do is to do some functional testing. Usually around 3 to 4 years ago, I would send patients for more functional testing, and sometimes a cardiac cath. Now we do the FFR with the CT. FFR with CT is going to help you because when it's in the moderate range, you send them for FFR. It has a good correlation with the invasive FFR, and you can answer the question if your patient has something significant or not. And the last thing I want to leave with, of course, you have other applications. When you should not do a cardiac CT. Of course, when you have some renal issues and when you think that your patient is going to have some coronary artery disease, I think, to be fair, just send them for a cath, because the cath, you don't have to expose them to the dye and the radiation twice. If they have a really uncontrolled AFib and the heart rate is going fast, try not to do it. And if you really think that, this patient is a very high risk, I think it's fair when you think that they need to fix something, it's fair to do this. And, for cardiac CT, when you have a chest pain or shortness of breath, you can answer a lot of questions in one setting, which is, so if they have something with the esophagus, they have a hiatal hernia, they have, something with the lungs, you can cover everything, I think, in one setting. It can answer the one question, or most of your questions, you can answer in one stop. And it can go on and on. Maybe I will need another hour just to cover the whole thing, but it is a really helpful tool. This is just to give an example here. This patient had shortness of breath. You did the cardiac CT. You can answer. And by the way, if you do the triple protocol, so you can answer. You can answer a question. If your patient has a dissection, you can answer if your patient has coronary artery disease, the extent of the disease. When you do a calcium scoring, so this patient had pericardial effusion. Even you can differentiate between transudative and exudative, by this, just in one setting. See how many questions you have an answer to. So this is how cardiac CT changed my practice over the last 5 years, as I was able to provide better service for my patients. I think, yes, it's unfair, to keep going for this. And if there's any questions toward the end, then we can answer those questions. Okay?
Thank you, Dr. Haytham. Yes, 15 minutes wasn't enough to cover cardiac CT. I think you did a fair job with that, and you definitely did cover the calcium score. on that. I think the only thing next year, yeah, maybe just calcium on the aortic valve. Now it's my great pleasure to present our next speaker, my batchmate. I have Dr. Ahmed Mansour, a multi-imaging modality cardiologist with advanced training in CT and MRI and echocardiography, who came to us all the way from Ireland to teach us about, I hope 15 minutes will be enough for you, for myocarditis, MINOCA, amyloidosis, and more, CMR and real-world practice, and there's going to be more show and tell kind of presentation. Dr. Ahmed, the floor is yours.
All right. Assalamu alaikum, good afternoon, everyone. Moving directly to the topic, saving time. Is the pointer working there? All right. All right, so the objective here for this short talk is more to talk about how much the cardiac MRI nowadays is becoming worldwide more available, and it started to be an essential diagnostic tool and a turning point in making the diagnosis in many of the cardiology cases, guiding management and telling something about the prognosis. And so how does it do that? Because cardiac MRI, in fact, could offer you many assessment of many parameters. In one test, cine imaging is good in getting the function and structural, as well as some hemodynamic assessment. Tissue characterization tells you how is the tissue in terms of infiltration, the fibrosis. The gadolinium enhancement shows the scars, active inflammation, infarction, stress perfusion, and generally perfusion could be applied for different reasons. And we should remember also this is a non-invasive test with good quality of the imaging. So to highlight this concept, the best thing to do in short time is to give good examples to show how what is the importance of the MRI here. So 2 cases of MINOCA, myocarditis, Takotsubo, 1 case of cardiac amyloidosis. Moving to the first scenario, so a 41-year-old gentleman who's a smoker presented with a chest pain radiating to the arm and jaw. ECG showed some abnormalities, a little bit non-specific. Troponin was consistently rising. So the impression here was that this is more likely that he's having an acute coronary syndrome. Cardiac coronary angiogram is done, and that did not show the culprit lesion. In general, it showed non-obstructive coronary artery disease. So you end up here with the working diagnosis of MINOCA, which is myocardial infarction with a non-obstructive coronary artery disease. So cardiac MRI was asked for as inpatient to trying to get an answer. So here, I found that for the guys who are not familiar with cardiac MRI, I find that it's easy for everyone to understand the concept of these sequences. So I'll go through that very briefly. So the imaging and the upper imaging are representing what we call a fat-suppressed T2 weighted imaging. And this is helpful in detecting the presence of edema in the myocardium. And the lower images are the delayed enhancement images, and that shows whether there is an evidence of scar inflammation or infarction. Okay, so if we look at the upper right image, you see that this is a short axis at the base of the left ventricle, and if you see that the area in general is gray in color, that is how it's normally looking like. But the one that is where the arrow is pointing to, you can see that there's some brightness, and this brightness is a high signal referring for the presence of edema. Now going down on the right side, the image is the delayed enhancement imaging. Here, as I said, it is to detect whether there's a fibrosis, inflammation, or infarction. And the dark area of the LV here, representing the normal-looking myocardium. But the arrow here is pointing toward a hyperintense signal. So it could be now fibrosis, infarction, or inflammation. But with the presence of edema, we know that there is something actively happening here. So it's either infarction, or acute or subacute infarction, or an inflammation myocarditis. But when we look at the distribution here, the distribution doesn't go with the myocardial infarction. It's mid-wall, more toward subepicardial. So that's the classic distribution in myocarditis. Now, this MRI repeated 6 months later. So if you look at the left side of the screen, the T2 image here shows that the edema has resolved now. And the delayed enhancement image shows that there is now a scar there. So the diagnosis here is likely myocarditis, most likely post-viral infection, self-limiting. Okay, so moving to the second scenario, this is a 79-year-old lady who presented to the emergency department with this chest discomfort, palpitation after emotional stress. In fact, she was attending funeral of her close friend who died suddenly. So she was at increased stress. Interestingly, she had history of Takotsubo a few years ago. And we know that she got good recovery from that. Now, the patient in the emergency, she had remarkably elevated troponin. However, I would say it's modestly elevated, but significantly rise in the pro-BNP level. So the clinical impression here that more likely that she has recurrence of her previous Takotsubo. But the echocardiogram here showed kind of almost normal. Maybe there was very subtle regional motion abnormalities. So we know that the classic features Takotsubo is the apical balloon. It could manifest differently, sometimes reverse, sometimes but that's the classic one, and it wasn't there. So the next step, she had coronary angiogram, and that didn't show obstructive disease, so mild non-obstructive disease in this case. So to understand more the situation here, cardiac MRI was requested. Okay, and we are going to use the same sequences here, helpful in such case. So on the left side now, you see that that's, again, the T2 weighted image. And you see that now so this is at the mid-cavity level of the LV. And you see that there is a bright area, okay, compared to the other area of the myocardium. This bright area representing the presence of edema. When we match this to the image on the right side, the delayed enhancement image, we see that the myocardium looks nicely dark. So there is no evidence of disruption here, so no evidence of inflammation or infarction or scarring. And accordingly, this combination goes with the diagnosis of stunned myocardium. We see it with the high adrenaline surge, like in cases of stress-induced cardiomyopathy. And also we see it in cases of pheochromocytoma, but that doesn't fit the scenario here. So these two cases representing the MINOCA myocardial infarction with non-obstructive coronary disease, so it's working diagnosis, and it's in up to 15% of cases of acute coronary syndrome, we end up with that working diagnosis of MINOCA, and cardiac MRI gives you answer in almost 80% of cases. In fact, the cases that I found that myself that MRI doesn't help is the cases where the damage is too small, or maybe the MRI done in a bit later time. So cardiac MRI here is very good in sorting the dilemma here, avoiding unnecessary antiplatelet, unnecessary workup for thrombophilia, or chasing the source of emboli, and also to give an idea about the prognosis here, as well as advices, as well as a possible treatment needed. Moving to the next scenario, a 36-year-old lady who had for some reason attended before, a couple of years before, and she had Holter, an echo, an ECG were all normal, and now she's coming back with palpitation and chest tightness. The ECG here showed some new changes, but non-specific, and the echocardiogram, in fact, the study, because of increased body mass index, wasn't very informative. So you get the impression that she has preserved ventricular function, not too many information. The lab here was surprisingly showing a remarkable results that doesn't see commonly in this age group with the high pro-BNP. Troponin was borderline increased, and there was also some increase in the CRP level. So to try to get a little bit of answer for this constellation of abnormalities, cardiac MRI was requested. So as you see here now, this is the cine image of 4-chamber view, okay? And the LV, clearly that is an LV and RV that they have clearly that by eyeballing normal function, systolic function. And then there is a little bit of LVH there. The left atrium appears a bit dilated as well, okay? Maybe mild to moderately dilated. Then if we go to the stack of the delayed enhancement, we see now that myocardium doesn't look healthy in this case. So there is a hyperintense signal, the bright areas, more in the basal segments, okay? And they take different distributions. So there's some transmural, some subendocardial, doesn't follow coronary distribution pattern. And there is another feature here, which that you see that the blood pool doesn't look very bright, okay? And that we call this difficulty nulling here, and it's a feature to represent the diffuse infiltration in the myocardium, which is commonly seen in cardiac amyloidosis. This is again very helpful test to do when we are suspecting infiltrative cardiomyopathy, which is TE1 mapping. Okay, and that helps to get the percentage of the how much of the extracellular volume. And in this lady, she had extracellular volume up to 50%, which is significantly high. And it's almost pathognomonic here for cases of amyloid, because in fact, amyloidosis is unique in causing very, very high increase in the extracellular volume. Okay, so the diagnosis here was straightforward, that this lady, she had cardiac amyloidosis in young age, and her hematology workup was confirmed that she has the, So her hematology workup confirmed she has the, how to go back, sorry, yeah? Okay. Yeah, so hematology workup showed that she has the light chain, systemic light chain amyloidosis. She didn't have a multiple myeloma, but she has a dysfunction in the plasma cell, and she was referred for treatment. So you could see that here, how cardiac MRI take the shortcut toward the diagnosis and toward the management as well. So the take-home message here is A cardiac MRI nowadays is a very essential diagnostic tool. It saves a lot of time, okay, and saves the patient from having unnecessary further workup, unnecessary treatment, and hopefully that this becomes more and more available in Libya. Thank you.
Yes, thank you so much. You've been on time. It was a really interesting lecture. Now let me introduce Dr. Salim Yunus. He's an assistant professor, University of Manitoba, Director of Nuclear Medicine Department, Diagnostic Imaging Service from Canada. Welcome, sir. You have the stage now.
Thank you very much. Assalamu alaikum wa rahmatullah. It's end of the day, last session, last day, so woke up for me for the next 15 minutes. We're going to talk about functional imaging. The guys, thanks for them, they talk about the anatomical imaging. I have no disclosure. We're going to speak about the SPECT, PIT, how SPECT and PIT works, what's PIB in cardiac amyloidosis, what kind of radionucleotide we use, what's the indication, what's the advantages and disadvantages. This is the first guy, Helman Bolmaget, who injected radon to measure the circulation in 1927. Then a guy from Germany came, his name is Myron Brinsmantel. He injected radiolabeled albumin also to measure the circulation in the body. And then this is the godfather of nuclear medicine. His name is Hal Anger. He is the founder of the gamma camera, and still up to date we call it Anger gamma camera based on his name. And that was in 1952. And that's the beginning of nuclear cardiology. As you can see, the incidence rate of heart disease in US 2018 and 19 was the highest among all other causes. In those people with heart disease, coronary artery disease was 42%, almost half of the people have coronary artery disease, which is the leading cause of death in US. Now, we have invasive imaging and we have non-invasive imaging. We'd like to go always to the non-invasive imaging because it will be less consequences to the patient, faster, and you can have the results. It's widely used, and with the functional imaging right now, it added the sensitivity and specificity. You have coronary CT angiography and MR who have only the anatomical anatomy for the coronary stenosis and coronary artery disease. And then we have the hemodynamic significance of coronary artery disease, which can be assessed by SPECT, PIT, or MRI. As you can see with the non-invasive test, you can measure the myocardial flow, you can evaluate the function or the pumping function of the heart, and you can visualize the site and the location of the heart attacks. So myocardial perfusion imaging usually to evaluate regional myocardial blood flow and viability. We inject the tracers. The tracer will go through the blood vessels to your coronaries, and if there's any significant stenosis, it will show up on the images. And that's why it's called functional imaging and not only the anatomical imaging. And with the new advances of gated images, we added SPECT. And with SPECT, you can measure the EF, you can see the contractility of the heart, and you can do gated images, which adding the overall accuracy of the test. In meta-analysis done for 117 SPECT study, the sensitivity of SPECT was 88.3%, while the specificity was 75.8%. It's higher sensitivity, a little bit lower specificity, but we're going to come and speak about PIT, which have a higher specificity as well. People who have abnormal myocardial imaging usually have an annual heart event of 6.7%. So when you have a perfusion defect, when you have abnormal MIB scan, the annual cardiac event is 6.7%. So what's SPECT? It's single photon emission computed tomography. Single photon because when we inject the tracers, it will emit photons. Those photons will come to the detectors and it will be picked up by the detector. Emission, it's not a transmission. X-ray, CT scan, you have a transmission. In SPECT imaging, we call emission scans, and you do the computed tomography to have the final signal, and you have the image analysis. And this is how SPECT is working. You have the body there. You emit photons. Those photons will go to the collimators. It has to go a certain direction, because if it's going parallel, it will cause attenuation, and we're going to face some attenuation artifact, and we're going to speak about that. Then it will go to the crystals, which will turn the photons to a light. Then after that, it will be picked up by the computer to be transferred by the algorithm to the images. What's the indication for that? Usually, predict obstructive CAD, you can see the number, location, and the significance of coronary stenosis. It can guide the medical treatment and for risk stratification of the patients, and it can assess cardiac viability. Preparation is easy. You don't have to eat anything for 4 hours, no caffeine for 24 hours, because caffeine can interfere with diabridamol, and then you will have a false negative result. So that's why you have to stop coffee, any coffee-related or caffeine-related. You have to consent the patient, and you put IV line, and you inject the dose. Lots of contraindications. Asthmatic patient, if you give them the vasodilator, sometimes bronchospasm, so it's severe asthmatic people, we don't do that for them. If you have a complete heart block, if you have systolic blood pressure less than 90, if you use the aminophylline, or if you drink it coffee, if you have any hypersensitivity to diabridamol, then those are the contraindications, which is common. 2 types of stress testing. We do exercise, which is submaximal and maximal, but people who have amputation, all people who cannot do exercise, we do the pharmacological medication, and there are 2 types. You have the vasodilator, and you have the inotropic medications. If people have allergy, like asthmatic people, to diabridamol or adenosine, we do a dobutamine maybe scan. Usually the protocol for that, we inject the patient for the first 4 minutes. After that, we wait for another 3 minutes. We inject the MIBI, which is the radiotracers. Then after that, we wait for 2 minutes, and we inject the antidote, which is the aminophylline. And then we send the patient after 60 minutes for imaging. If you are doing exercise, you exercise your patient. When they reach the maximum 85, the maximum target heart rate, you inject them with radiotracers. Then after that, you continue for 1 minute. Then you stop the exercise test. You send them to the department. They wait for 45 minutes to 1 hour. Then we will do the imaging. 2 types of radiopharmaceuticals common use for SPECT. We have thallium, which is calcium analog. The problem with thallium, they have low energy photons, so you have fuzzy imaging. It's not good image quality, and you have longer half-life, so you have more radiation dose. The other alternative, which is the most commonly used, is the technetium. They have high energy photons, and that's giving us a better image quality, and they have short half-life, so you can increase the dose for the same amount of radiation. The down point for that, sometimes you have an attenuation artifact, like breast attenuation, subdiaphragmatic soft tissue attenuation, and that should be taken care of. I'm going to skip that for the time being. Usually when we do the interpretation for the images, it's easy. We categorize that normal, mild reduced uptake, moderate, severe, or no uptake. The first slice, you can see no problem at all, and it's normal because you can see the good donut shape. The second slice, you can see a filling defect or hypoperfusion to the inferior wall, both at rest and post-rest images, and that's an infarction. The third one, what we call reversibility, you can see the post-rest filling defect and normal wrist scan, and that's what we call ischemia. Technical artifact, it's breast attenuation. We minimize that by the technetium instead of thallium, and also we have the gated images. If you have good gated images, good EF, good contractility, that's probably an attenuation artifact. Inferior wall attenuation, also we have the gated images, which minimize the inferior wall attenuation. And the last one, when you have a GI activity close to the inferior wall, we ask the patient to drink waters, and we do imaging again, and that will eliminate the elimination artifact. This is how we do the images. You have the short axis, you have the horizontal long axis, and you have the vertical long axis, and that's how we cut the image slices on our scan. So this is a normal scan. Good donut shape, good perfusion all over the left ventricle walls. They have no problem. This is a pre-CABG scan on the left side. You can see there is LAD disease, the anterior wall and the anteroseptal wall. You see the filling defect. Then the patient went for a CABG surgery, and you have a normalization of the anterior wall and the septum. PET scan, which is the new modality coming to the market, will replace SPECT in the future. We use perfusion tracers like rubidium and ammonia, and we have the metabolic tracers for viability like F18, FDG. How it works, usually you put the patient on the table, you have 2 photons, we call them annihilation photons, simultaneously, not like the SPECT where you have single photons. They will be detected at the same time. They have high energy, which is 511. That's why you eliminate the attenuation artifact, which can happen with the SPECT images. What's the advantages? High spatial resolution, improve the attenuation and scattered correction, and you can do quantification of regional blood flow. This is very important. You will face balanced multivessel disease. You do a quantification for the SPECT. So when you have the 3 blood vessels affected, it will show up for you as a normal because all of them are abnormal. In the PET scan, you can do the quantification of regional blood flow, and that can eliminate the problem, which is the balanced multivessel disease. And this is the trend these days, and it will come more and more in the future. PET CT has a sensitivity and specificity of 95%. When I spoke about SPECT, I said 67% for the specificity, so it's more specific and sensitive compared to SPECT. This slide just to show you the overall sensitivity of many studies done of the SPECT CT, and you can see it's ranging between 87 up to 100%, and the overall accuracy is very high for the PET compared to SPECT. People talking about radiation dose. Everybody's afraid. It's low dose, it's not really high. However, you can do 1 day or 2 day protocol for systemic. You can see the radiation dose. The highest among thallium, which is 29.3. The lowest will be in a PET CT where you see rubidium and ammonia. And the average total effective dose is 30.3 millisievert for thallium compared to 2.7 for PET CT, significantly reduced dose. We're going to talk about cardiac amyloidosis, which is destructive disease due to extracellular deposition of amyloid. You know, there are 2 main types, constitute about 95% of the cardiac amyloidosis, which are ATTR cardiac amyloidosis, and the AL, which is light chain cardiac amyloidosis. Several tests for cardiac amyloidosis, including EKG, MRI, echo, technetium IPPB, and tissue biopsy, which is the definitive for diagnosis. How it's PIB? You see the planar images, and you see the SPECT images. So how they categorize that? Grade 0, if the uptake on the heart, if you can see no uptake or abnormal, and this is negative for ATTR cardiac amyloidosis. Grade 1, the uptake less than any adjacent rib, which is, we will come to that, equivocal. Grade 2 and 3 will be equal to adjacent rib or more than the adjacent rib. I'm talking about the activity. So if you have grade 2 and 3, that's suggestive for cardiac amyloidosis. And we have the other one, which is the semi-quantitative analysis or evaluation, which is the heart to contralateral ratio. When you measure the heart ratio, the uptake in the heart compared to the other side, usually it's more than 1.5. I'm going to speak that for reporting, not suggestive, when you have a visual grade 0 for the uptake in the heart. Equivocal, which is a problem for the cardiologist right now. When you have a grade 1 of the quantitation, that's an issue to the cardiologist because it will be equivocal and they will send him for another further testing. And strongly suggestive for ATTR cardiac amyloidosis, which is grade 2 or 3, the uptake in the myocardium equal to the adjacent rib or more than the adjacent rib. And you can see also right now with the SPECT CT images. I will give you an example. This is an uptake even more than to adjacent rib. It will be gradual as grade 2 or 3. But with the added of SPECT CT right now, you can see the difference. This is not a cardiac amyloidosis because it's a blood pool activity. If you can see the CT anatomy on the SPECT CT, it's not within the myocardial muscle, it's within the blood pool activity. So within, this is a negative for ATTR cardiac amyloidosis. So SPECT CT added the value over the planar images to measure or to have a definitive diagnosis for the ATTR cardiac amyloidosis. You can see also in this one, the amount of radiotracer activity is a blood pool activity, not within the left myocardial muscles. My take-home message, so SPECT CT right now eliminated the equivocal results. The recent data and literature talking about that, and they said if you have a positive SPECT or SPECT CT images, regardless of the scoring, it's a positive for ATTR cardiac amyloidosis. And this will be good for the cardiologist because it will eliminate the equivocal finding on the visual scoring. Take-home message for everybody: SPECT widely used technique to identify coronary artery disease. It should be used for intermediate probability of coronary artery disease. You don't need to rush and send the patient to the cath lab, and you know what's the consequences can happen from the interventional angio. PET has low radiation dose, faster imaging, good image quality, no attenuation artifact. This is the trend coming, and it will become more and more popular in the market. And this will be with the quantitation of blood flow. It will be the gold standard for coronary artery disease. And BYB has a higher sensitivity for ATTR cardiac amyloidosis. And thank you so much.
Thank you so much, Dr. Salim, and very comprehensive and nice presentation. We're going to open it to the questions. If you have any question, please come to the podium. Dr. Salim, if you have just stay, I do have a question to you till we get any of the audience. So for practicing cardiologists in Libya, as you know, there's no nuclear cardiology lab, and it needs a lot of investment. So the common question that comes to everyone's mind is said, why I invest so much money and time to start a lab ordering SPECT and CT while I can go directly for the heart cath? What would you answer them?
You have intermediate probability, you have high probability, and you have low probability. The answer will be the intermediate probability is about 20 to 80% of your population. If you're going to insert any patient with intermediate or low probability to the cath lab, that will be more invasive, more radiation dose, more risk to the patient, a challenging test. So when you have the alternative modality with low risk and low radiation dose and faster technique, because if you send the intermediate probability to a MIBI scan, which if it's available, you can eliminate a very large number to go to the cath lab. What's the cost of the cath lab? When you send any patient to the cath lab, the cost will go up and up. So basically, when you look at the nuclear medicine, you think you are spending money, but when you eliminate a lot of patients going to the cath lab, it's cost effective, and also it's good to the patient to prevent any future intervention. So that's the answer to your questions. And also the standard of practice right now, they do PET and SPECT for any intermediate probability for the patient with coronary artery disease. So money, it will not be the issue, because if you look at the consequences and the money we spend on the cath lab right now, it will be overcome the maybe and SPECT images in the future.
And if they have to choose between PET and SPECT, they're going to invest the money, what would you recommend?
Yeah, PET more expensive. If you have a low PMI, send your people to SPECT images. People with high PMI, or if you have a normal maybe, then they will go to the PET imaging.
Yeah, and PET will have other non-coronary functionality, right?
Yes,
Yeah, for example, functioning.
And also you can detect any extra cardiac finding. I received the patient for a MIBI scan. We did the MIBI scan, then after that we do the SPECT CT, which is for attenuation correction. When I was looking at the CT component, I saw a mass in the right breast. System maybe can be picked up by adenocarcinoma of the breast. So the patient has normal maybe. I reported that they have a lung mass. It was adenocarcinoma of the breast, and he was sent to the surgeon after that. So the utility of SPECT CT, you can do two imaging, the functional imaging, and you can assess the anatomy for the heart and for the extra cardiac finding around the heart.
Extra cardiac, and PET will cardiac amyloidosis, endocarditis,
yeah,
and
the role of
viability.
PET in myocardial inflammation is wide. Maybe in the future we're going to talk about myocardial inflammation in amyloidosis, in sarcoidosis, and it's going more and more tracer coming to the market, and more indication for infection and inflammation in the nuclear cardiology.
Riyad, do you have any comment on this?
Any usage in suspected endocarditis?
Sorry?
Any usage for...
The utility of nuclear and endocarditis, nuclear medicine and endocarditis cases, like a prosthetic valve devices.
Yes, that's why myocardial inflammation, infected prostatic valve, usually right now we do it with CT, lots of inflammation, prosthesis. Sometimes you see the prosthesis in the any organ in your heart, it's anatomy, but when you do the PET CT, it will be having high uptake, so that's an indication for infection and inflammation.
And actually, this was added to the modified Duke criteria, because a lot of times, especially people who does TEEs, you build up like a fibrous tissue on the pacer wire. It's hard to tell, is it thrombus, vegetation. A lot of these patients, they have like a dialysis catheter. You're not sure, so PET is very helpful on those cases.
People, they say you have the anatomical, the functional or the physiology will change 9 months to 12 months before you can see anatomical changes. So when you do the PET or PET-CT, you can detect early lesions or early infection inflammation before you can detect it on the anatomical imaging. And they say the gap is about 9 months to 12 months period. So you can have the probability to detect early lesions, early infection, anything before you can see it on the anatomical imaging.
Thank you so much. Yeah. Any other question from or comment from Dr. Azza? Can you turn the mic on if you don't mind? The mic on, it's not on.
Dr. Haytham and Dr. Ahmed Mansour. First, Dr. Ahmed Mansour. My comment is already I talked with Dr. Hariri yesterday about heart failure clinics. You talk about a case of cardiac amyloidosis and you mentioned that there is a normal biventricular function, but you don't specify what are the function, systolic function or diastolic function.
Sorry, can you say that again? A bit, I didn't get that. Can you say it again, sorry?
Third case.
Yeah, the question again, sorry.
The question is that you mentioned that the patient has normal biventricular function by echo, but you don't specify what are these functions, either the systolic or the diastolic function. The question is, do you adopt a protocol for assessment of diastology in your patients when you are suspecting a case of HFpEF? There must be a clinical syndrome of symptoms and signs of heart failure, in addition to the lab work, like the BNB, pro-BNB, and you mentioned that it's markedly elevated. So the next step is the algorithmic protocol for assessment of diastolic function. The velocity and the medial and lateral sides of the mitral annulus, the E over E prime, the left atrial volume index, and the tricuspid regurgitation velocity, and how much you can collect score from these figures. And so you can document that you have an echocardiographic signs of HFpEF, and in addition to the lab work and the clinical status, the patient has diastolic abnormality, not diastolic dysfunction by echo. So you must do a CMR as a next step. But if you mention that the patient has only biventricular normal function and one function.
All right, okay. So, in the cardiac amyloidosis, okay, sometimes the diastolic function is normal and the patient has, sometimes it's only when it's too advanced, okay, that the diastolic dysfunction starts to be abnormal. And cardiac MRI, the cardiac MRI is not
Dr.
better.
Ahmed, I don't think so. I think you have abnormality in the diastolic function by two-dimensional echo at first. When it becomes more advanced, you can find the advanced modality having severe dysfunction like the cherry on top or the global longitudinal strain with apical sparing. But I don't think that you have a patient with cardiac amyloidosis with symptoms and signs of heart failure and markedly elevated pro-BNB with normal diastolic function. This is not cardiac amyloidosis.
Yeah, so in the case that I presented, she has an advanced, okay? It does look like it has a preserved, and if you have done the spical tracking and longitudinal shortening, I'm sure it will be abnormal.
Yes.
Okay, it wasn't done in this case because the echo quality was very low. But that is not, that sometimes is misleading because there are patients who you don't see the classic shape on the spical tracking when you see that the apical looks preserved and it's more toward the base. So what I'm trying to say that it could be sometimes deceiving because what happened now, the infiltration there is from 0 to 100%, and that's the infiltration go all over this spectrum. And that's why, nowadays we believe in the multi-modality imaging in terms of, so MRI, sometimes we ask for PET scan as well, the DBT, to help me again to go. So this maybe it was straightforward case, but we have a lot of...
I'm just saying this to make the audience know that there is a sequential investigations starting from the clinical investigations, how much the patient is suffering from heart failure symptoms and signs, and then pass through the ECG and the echo and detailed echo study before we jump to another more expensive and more prestigious investigation.
Yeah,
like
I got
the
your point.
CMR
Yeah,
or the nuclear
I
study.
totally agree. Yeah, so
Yes, okay.
so it is clinically it is very important to look all the features, and that's how you guide yourself toward trying to pick up the proper more advanced diagnostic tool. Okay, in cardiac, so in echo, so in ECG we know that the reduced voltage and all these features, maybe some degree of conduction abnormalities and all these things. Then you go with the echocardiogram. Now this lady, she had possibly find that she has impaired relaxation, which is abnormal for someone who is in 36-year-old. How the myocardium will look at the echo, is it bright, looking at that? So I totally agree that using clinical approach, I'm not saying that you have to do MRI for every suspected patient. That lady was because in a young 36, you had all these findings. Echo wasn't very helpful, ECG non-specific. So you ended up with a collection of features trying to figure out. In fact, when MRI was requested initially, we were thinking of some genetic, possibly cardiomyopathy. We did not think about the amyloidosis per se.
Because of her age, right? Because of her age. It's not typical for cardiomyopathy at this young age. I mean, you looked at then more imaging because of her age is not the classic for cardiac amyloidosis, right?
Yes, yeah. But the example here was to tell you when you are kind of stopped at certain points with a lot of differentials. So cardiac MRI here could give you a short answer sometimes, not all the times.
And the other thing, Dr. Azza, younger patient, they have markedly elevated E velocity, right? So someone 34, you expect, like we say the normal E velocity 10 and 7 lateral and medial, but younger patient expecting it to be higher. So maybe in some case, this one, even though it was lower, but doesn't meet that cutoff. I like what you...
Yes,
because we need to wrap up.
Dr. Ahmed. I just want another question with Dr. Haytham. I'm wondering if you already have a research for diabetic patients with suspected coronary artery disease, because your talk is mainly focused on the calcium score. So if you have a model for diabetic patients, including in addition to the coronary calcium score, the extra coronary calcium score, I mean the mitral annular calcification, the calcium in the aortic valve, ascending aorta, descending aorta, and maybe the abdominal aorta. You know that maybe 20 years ago, we considered diabetic patients as coronary artery equivalent until proved otherwise, but a large meta-analysis maybe 10 years ago is talking about that diabetic patients are not all the same. We have high-risk diabetic patients that they must be considered like coronary artery equivalent, and another low-risk diabetic patients. Do you have any model that can classify diabetic patients according to the calcium score, not only the coronary, because it is known that diabetic patients has more coronary calcium score in comparison to the normal or non-diabetic patients. So do you have a scoring system that classify diabetic patients into high risk and low risk according to coronary and extra coronary calcification together?
So I mentioned in the at the beginning, if the patient is diabetic, if the patient has a family history of premature coronary artery disease, and if sometimes we use lipoprotein A as well, calcium score probably is not going to help you. You have to go with the clinical sense, for this. So calcium is only the tip of the iceberg. So when you see it, it's always the question is, do you have any soft plaque? And if you're diabetic, I'm sure that there's some soft plaque. So if, you have to go with clinical impression for this. So this is answer your question. If your patient is diabetic, and especially if, they have been diabetic for a long time, or if it's not controlled.
No, I mean not diabetic versus control or non-diabetic. I mean all patients are diabetic. Who are the diabetic patients that you consider it a high risk? You know that the chronological age is not that important like the biological age. The biological age is the age of your arteries and your coronaries. So a lot of investigators talk about the extra coronary calcium. It is not only the coronary calcium score, but the calcium
score. You mean like for the aorta?
Valves and in aorta.
Yeah, I use it. Every time when I look at a CAT scan, I start, from the bottom, and if I see some calcium in the aorta, you're wondering that if there's something else, if it's including other places. Yes, so we use it. If I see calcium in the aorta, this is I will, for risk stratifications, probably is going to be higher. But if there's a tool specific, for the aorta, I'm not aware of it. I didn't use it, but what I can tell you that in this case, now here we talk about asymptomatic patients, right?
Yes,
asymptomatic patients.
Yes,
yeah.
Asymptomatic, just for screening.
Yeah, for screening.
And risk stratification.
And screening, are we talking about screening for coronary events? For screening,
maybe
is it for coronary events?
Maybe to risk stratify their maybe coronary status. Yes, to risk stratify these patients. How could you say that this diabetic patient is low risk and this diabetic patient is high risk?
Well, yes, I use calcium score, for this.
Coronary. That's
coronary,
all coronary.
Because, we know the saying that, your age is reflected by the coronary arteries. Many times, especially, not only cardiac CT and cath, they will tell you that this person has coronary arteries for a 70-year-old lady, and even this patient is like 30, and vice versa, for this. So the calcium score, it's just will give you the tips of the iceberg. Now, still, we're talking about asymptomatic patients. If you have a suspicion, sometimes for some, for clinical suspicion, you think that you might find more, and the patient ends up with a coronary angio. This is when it comes, the burden of the, plaque. It can help us with this. I don't know if this answers your question, but for diabetics, to reclassify them, for this, and for coronary events, still I will use the, for cardiac CT, I will use the calcium score and the burden of the plaque.
Thank you very much.
Go ahead.
Sorry, Dr. Salim, may I ask a question about the use of PET scan in pericardial disease? Can it help us in differentiating the etiology of pericardial disease? Is it, or just acute, chronic, and fibrosis? Does it help etiology? Can give us a hint about etiology?
Pericardial.
The pericardial disease, pericarditis, does it help us? How much can... yeah.
Right now, the answer is no, because the specificity will go down in that region with the tracers that we have. But there are new C11 tracers coming. It needs to be approved by FDA, which is coming soon, and that will help to differentiate what you're asking for. But right now, the answer is no. C11 palmitate, it's coming to the market, and that will be an indication for
Thanks so much. So we're going to wrap the question, but I want to finish with Dr. Haytham's case. So that your coworker who asked about that, he's worried about his risk and being proactive. What a calcium score level that you would recommend this patient to be on aspirin and statin? Right, because that was the main purpose, right? You want a risk enhancer. If the results came abnormal, that will make a stronger case to convince the patient to be on statin, right? And so is there a cutoff number that the
question, when you can use which calcium score when you have to think about using aspirin and statins?
Yes, yes.
Yeah. So for statins, when it's, you have to go by, the level. So when it's greater than 100, when the score is greater than 100, for sure I'm going to use statins. If it's greater than 300, I will use a high intensity statins. And the goal then is going to be different. So as we showed in the slide, if the calcium score is 300, I will treat the patient like they had a heart attack yesterday because the outcome is like the same. So if you have a patient with a heart attack, let's say that's a month ago, your goal for the LDL for now, we go for less than 55 milligram per deciliter. So if your calcium score is 300, my goal is going to be less than 55. If it's in the intermediate range, probably less than 70. And if it's less than 100, then I will go for less than 100. Aspirin, if it's greater than 100, the calcium score is greater than 100, then I will use aspirin 81 milligrams for primary prevention.
So would it be fair to say if it's more than 100, yes for aspirin and
Yes.
statin?
If it's greater than 100, it's aspirin and statins.
Less than that, there's no significant benefit.
Statins, yeah, so when in one of the slides, when you see that, when it's the power of 0,
Yes.
to treat, the number to treat is, infinity, for this, right? So there's no benefit, when the calcium is 0. If it's greater than 100, in my practice, I know that there's some calcium, and now we have to go with if it's greater than 75 percentile versus less. When it's greater than 100, greater than 1 and less than 100, I still use statins. There's a benefit for statins. I don't use aspirin when it's less than 100. When it's greater than 100, I use aspirin and statins. And then it depends, your goal. Then for risk stratification, you have to go for the goal. When it's extensive, then you need to be more aggressive, of course.
Totally agree. I do the same thing. Last question with Dr. Salim,
Question
then we'll
to
conclude the
Haytham.
session.
The coronary calcium scoring, the numbers 100, 400, or 1,000, it's distributed all over the blood vessels and not causing major obstruction, versus if it's accumulated in one area and causing major obstruction. What I mean, if you have a calcium score of 700, but it's distributed along the blood vessels and it's not causing major obstruction. Sometimes you have a calcium score of 100, but it's coming to the left main or LAD. So what are you going to do about that?
This is an excellent question, and we get this a lot. So there's no clear data. So if it's, let's say that you have a calcium score of 200, and most of it's in the left main. It's 100, most of it's in the left main. So does that make the patient has a higher risk? There's no clear data for this. We don't treat them differently. So the short answer is we don't treat them differently. I think there's more going, so we're waiting for more data, but we don't treat them differently. So we go just with the risk stratification. If it's greater than 100, it's the same. But yeah, it's always, it's an excellent question.
Thank you so much, everyone, for attending. Thanks for all the speaker and my co-chair for this session. This is conclude the scientific program for Cardio Libya 11. It was wonderful to see all of you. I hope you all learned, make new friend, and looking forward to see you next year. Inshallah, at 4 o'clock, we're going to have either the Jeopardy session competition between the team. We have technical issue, but we'll try to get that, or the board meeting for the LCS to talk about the future steps. I would love to see you all here in this room at 4. Thank you.